Good evening, everybody, or good afternoon, or maybe even good morning, wherever you are. My name is Hani Wadei. I'm one of the kidney transplant nephrologists at Mayo Clinic in Jacksonville, Florida. I'm moderating this session and this talk. It's LDL apheresis and pediatric FSGS. Our speaker this evening is Dr. Katherine Twombley, which actually has multiple hats. Dr. Twombley is a professor in the Department of Pediatrics, Division of Pediatric Nephrology at MUSC Medical University of South Carolina in Charleston, South Carolina. She is the chief of pediatric nephrology. She's the program director of the Pediatric Nephrology Fellowship Program. She is also the medical director of the adult and pediatric inpatient dialysis unit in Charleston, Lancaster, and Orangeburg in South Carolina. She's the medical director of the pediatric kidney transplant program at MUSC. She's very active at the American Society of Transplantation, and she is the immediate past chair of the Pediatric Community of Practice, and she's a member of the Translational Grants Review Committee. She's also the president-elect of International Pediatric Transplant Association. She published more than 70 peer-reviewed manuscripts in the field of pediatric nephrology, FSGS, and I'm sure recurrent FSGS. And she is the sole editor of a textbook, Challenges in Pediatric Kidney Transplantation, a practical guide which was just published in 2021. And she also published recently another book by the name of First Do No Harm, a physician burnout and mental health guidebook from medical school to retirement. We just want to let you know that this educational activity is provided to us by Opus Medicals, who designates this course for a maximum of one AMA PRA Category 1 credit, and also offer ABIM MOC points. Without further ado, please join me in welcoming Dr. Twombley today for the presentation on LDL apheresis and pediatric FSGS. Dr. Twombley, we're very happy to have you this evening.
Thank you for the kind introduction, and thank you for the invitation from Opus Medicus and Konica to talk to you about FSGS and pediatric, specifically FSGS and LDL apheresis. These are some pictures of my beautiful city, Charleston. If you've never been, you should visit. It's a wonderful city. All right, my disclosures. I am on the FDA post-approval study for LDL apheresis. I'm a consultant for Horizon and an advisor for Alexion, but none of the things I do with them is going to relate to this content. The objectives. So first, I would like you to understand the complications of untreated FSGS, examine the benefits of LDL apheresis with FSGS, and then review the limitations of LDL apheresis with FSGS. So this is a slide I saw J.J. Zaritsky present, and he was kind enough to let me borrow it from him, but why I and all nephrologists hate steroid-resistant nephrotic syndrome. So there really is a lack of diagnostic tools to guide treatment, right? So when a patient is diagnosed with new onset nephrotic syndrome, we put them on steroids, at least in children. If they don't respond, there's guidelines on maybe you should try a calcineurin inhibitor. Some people try mycophenolate. There's just no real, we don't know who's going to respond and who doesn't, and we don't know which patients are going to respond to which immunosuppression and which ones aren't going to respond at all. The cures sometimes can actually be worse than the disease. I don't know if y'all have ever you know, you've heard of the terrible twos, or it's actually the terrible threes, but can you imagine the terrible threes with added steroids, right? And then teenagers, you know, they get, you know, even the young kids, they get obese, they get cranky, they get really bad steroid-induced acne, they get hyperlipidemia, high blood pressure, some get steroid-induced diabetes. And so all of these medicines come with side effects. There's a pretty high reoccurrence rate. It varies between publications, but if you average them all, it's around 50%. The literature tends to say it's lower in African Americans. That is not my experience. We have a high rate of FSGS in South Carolina, and I do not see FSGS discriminating between races or ethnicities in my population. There's 150 years of descriptive disease, but like I said, the diagnostic tools on who's going to respond to what is really lacking. And there's very little insight into the pathophysiology. We know there's a common endpoint for the podocyte injury, but we don't know what starts this process in a lot of patients. We do know it's immunologic in some patients because they respond to immunosuppression. There are patients who have genetic or familial mutations that cause this injury, and we just don't know. There are patients who we're still learning about a lot of these genetic mutations, especially APOL1 has been one of the most recent ones that's come out, but there's always new mutations being described, right? And there's a lot of heterogeneity within this disease. There could be more than 1,000 mechanisms of podocyte injury, but all we see is the podocyte injury itself. We don't see everything that happens before, and that's been one of the hardest things about this disease, is really trying to figure out what's going on. So, you know, the students and the residents and even the fellows, a lot of times they go, what's the difference between minimal change and FSGS? Or they'll say, oh, minimal change is good, FSGS is bad. Well, I have to remind everybody that minimal change and focal segmental glomerulosclerosis are pathology diagnosis. Those don't describe their clinical course, right? So this is kind of how I describe it to my trainees. So if you look at the circle on this kidney, this green circle, that is an area of FSGS. Just take my word for it. All these little green circles, they're focal circles, right? And within those focal circles are going to be areas of glomerular sclerosis. When we put our biopsy in, we take, hopefully, one, sometimes two little cores, and we try to get mostly cortex because that's where your glomeruli are. So if my needle comes here, when the pathologist reads my biopsy, it's going to say minimal change disease, okay? But over time, okay, these areas grow. Let's say I biopsy this child 5 years later, and my needle goes here this time. Now I've got a diagnosis of FSGS, right? Could this child have had FSGS the whole time? Absolutely. Your needle just missed it, right? Remember, there's 500 to 1 million glomeruli in a kidney, and if we're only taking 10 to 20, absolutely there's a chance we're going to miss it. But as time progresses and you see more of these lesions, then you're going to have a higher chance of getting it. So at least in children, primary FSGS is one of the major causes of nephrotic syndrome and end-stage renal disease. This is the most recent NAPROTIX data. Granted, it's old, but this is the most recent published. But this is the North American Pediatric Transplantation Centers and Trials group. And then they report that the reoccurrence of FSGS in these patients is usually between 20 and 30%. But like I said, it really kind of depends on the study that you look. But FSGS really is one of the top contenders in pediatrics. So For some reason, some of it may be epigenetic, who knows, the frequency of FSGS in children has really increased dramatically over the past 2 decades. There is a marked rise in the frequency in African Americans. Some estimate that it's 3 times more prevalent in African Americans than it was before. Some are speculating maybe APOL1. We don't really know. But there's really no increased risk of reoccurrence that's been published yet in the African American population. But like I said, in my population, it does not discriminate. Is this environmental factors, obesity, hypertension? Possibly. Are there genetic mutations that are being discovered? There's always mutations being discovered. But are we starting to see some of the variability in these clinical presentations in their course with like penetrance and heterozygosity and things like that? And one question that really, is still kind of a mystery is APOL1. So will a transplanted kidney from a donor with a high risk APOL1 genotype will they carry a higher risk for development of de novo FSGS? We don't know that yet. Right? We know patients that have, either are homozygous for the same APOL1 genes or heterozygous for 2 of the 2 different ones have a higher risk of primary FSGS. But what if they're not testing those and you put them into a patient? Do they have a higher risk of FSGS? So I think there's a lot of things that are really changing on the epidemiology side here. So when you think about the treatment for FSGS, so we don't see a ton of secondary FSGS in children. Yes, we have obesity in children, but typically they aren't obese long enough to develop kidney problems. We don't see a ton of diabetic nephropathy. I think I've biopsied 4 kids in my 20 years that I've been able to say they have real diabetic nephropathy from years of noncompliance with their diabetes, but typically we just don't see a lot of secondary. We see mostly primary. They present with the swollen eyes. They've been put on Benadryl or steroids for allergies, and then somebody finally decides to check the urine. Those kids are typically nephrotic range proteinuria, hypoalbuminemia. They typically have diffuse foot process effacement, and the majority of them respond to immunosuppression and RAS blockade. Secondary is usually one of those things where they present over time and it kind of smolders. They typically don't have non-nephrotic. They typically have non-nephrotic range proteinuria. So they have proteinuria, but not enough to cause swelling. And their albumins tend to be normal to low normal. They have more of a focal process going on, and you have to look for the underlying etiology of that. This was the recommended treatment from Trackman's paper from 2019, but then KDIGO came out with some guidelines in 2021 that said for children with calcineurin resistant, steroid resistant nephrotic syndrome, consideration for entry into clinical trials evaluating novel therapies on the horizon should be strongly considered. For example, post-approval studies for LDL apheresis are ongoing and provide additional clinical trial options for children with calcineurin resistant, steroid resistant nephrotic syndrome. So this is one of the first times they've kind of mentioned LDL apheresis. So I was glad to see that coming into the market, because you see in 2019, this paper up here, that's not even on the horizon with it. So, when I was a medical student, they always used to talk about which came first, the proteinuria, the hyperlipidemia. And we didn't really worry about the proteinuria as much, because the thought was the proteinuria is showing that there's something going on in the kidney, not that the protein was actually doing damage. Well, now we know that the protein's actually doing damage, right? So nephrotic range proteinuria, normal serum albumin levels, and preserved foot processes will not respond to steroids. Those are typically, steroid resistant. Historically, protein was a sign of damage, but like I said, we now know that's not true. When you look at what albumin does to the kidneys itself, this was a paper, I don't remember when this paper came out. It's relatively recent, but it's talking about albumin-associated free fatty acids induce penocytosis in the podocytes, and the podocytes actually internalize large amounts of extracellular fluid molecules, and the podocytes are supposed to prevent, the slip processes and all that from clogging. But when you lose albumin, you decrease the plasma lipid buffering capacity, and you get these elevated levels of free fatty acids. This leads to increased circulating of this ANGPTL4, which inhibits lipoprotein lipase, which breaks down your triglycerides, so then your triglyceride levels go up. You get this increased expression in the podocytes, which induces proteinuria. They're still not sure how that really happens. And then this excessive micropenocytosis actually leads to lysosomal dysfunction, which eventually leads to your podocyte loss. So we know that the protein in the urine, the albuminuria itself, causes you to lose podocytes there. So that's albumin. Well, now we have lipids, right? So when you're losing your albumin in your urine, the liver tries to compensate by upregulating the production of albumin, but they can't make just albumin. They make lipids too, right? And so you get this high hyperlipidemia, high cholesterol, and now you've got decreased lipoprotein lipase, right? All of this, you get increased IL-6, you get TNF alpha increase, you get, RAS increase, adipodectin decrease, and you end up with lipoprotein deposition in the glomerulus, which you get podocyte injury. You end up with lipids in the urine with the fatty acids and albumin. You end up with tubulointerstitial injury, interstitial fibrosis. The hyperlipidemia and high cholesterol and abnormal lipoproteins can cause vascular endothelial injury. You increase your reactive oxygen species. You get atherosclerosis, hypertension. These lipoprotein deposition in glomerulus also ends up in your mesangial cells, which causes proliferation and macrophage activation and glomerular sclerosis. So all of this is just really, really bad for your kidneys. And then the immunosuppression, right? Prednisone increases your lipids. So now you have a patient who's hyperlipidemic, has albuminuria, and you put them on steroids. And if they don't respond, they're on steroids, and now their lipids go really crazy, right? High lipids can actually affect the cellular uptake of cyclosporin. Okay, it is decreased by increased lipoproteins. The clearance of rituximab is enhanced via non-selective proteinuria, which is why they say if you can give rituximab when a patient is in remission, that's best, because if you give it when they're relapsed, having a lot of nephrotic range proteinuria, they're going to pee out a lot of it. And when you combine tacrolimus with a high-fat diet, you end up with increased low-density lipoproteins and their bioactive oxidized forms. And LOX1 is the major receptor of oxidized LDL. And when you get increased oxidized LDL and LOX1, it promotes the expression of TGF-beta, which equals fibrosis. So all of these are just bad. So immunosuppression, the cure worse than the disease? Well, in addition to all the effects that it has on the cholesterol and the triglycerides, these medicines can cause diabetes. They can cause tremors. They can cause hypertension, seizures, alopecia, weight gain, chronic kidney disease. Let's talk about dyslipidemias and chronic kidney disease, right? If you get elevated lipids and lipoproteins, altered sphingolipid metabolism in the kidney, impaired cholesterol efflux, you get lipid nephrotoxicity, you get glomerular injury, tubulointerstitial injury, and it can progress and accelerate your kidney disease. Can it get any worse? Yes, just give me a minute. All right, dyslipidemia and nephrotic syndrome and chronic kidney disease, right? Now you've got patients who have atherosclerosis. They're at risk of myocardial infarction, cerebrovascular injuries, okay? It just all packs on together and it's additive, okay? So there's treatments for hyperlipidemia, right? So we have conservative treatments, diet, weight loss, exercise, statins. By the way, for pediatric people, there is only one statin that comes in a liquid, and that is pravastatin. Our bile acid sequestrants, our fibrinates, none of those come in liquids. What's interesting is when you look, and I want you to remember this for in a little bit, these are all of your statins, right? The most that you're going to lower your LDL here is around 50 points. You know, every now and then, I don't check lipids on all of my kids for diagnosis. I check them when they don't respond to see if to steroids to see if I need to treat them. But I don't know, you know, every now and then the residents will send an LDL level on a kid that comes in with new onset nephrotic syndrome. And depending on how long they've been edematous, sometimes they'll have lipid levels in the 300, 400, 500 range. So taking a lipid level from 300 to 250 at most with a statin is probably not going to change your risk of cardiovascular events in the long term significantly. And then you have your bile acid sequestrants, which aren't going to decrease your levels that much. But, you know, the fibrinates are not FDA approved in children, and they really lack safety and efficacy data in children as well. And niacin, you know, we've put some kids on niacin sometimes, and it might drop at 17 points, but there's just not a lot of options. So now what, right? Well, we have this therapy called LDL apheresis. And this is what the machine looks like. The blood goes into a filter. The filter separates the packed cells from the plasma. There are two chambers here that have dextran-coated beads that the plasma goes through, and it binds the LDL proteins. This actually looks like it's going through this one right now, but it goes through one filter. Once that filter is saturated, it switches to the other filter, and then it regenerates the first filter. So it alternates back and forth as it removes lipoproteins. This is a schematic drawing of it in the regenerate solution, which is usually LR. And it just regenerates, and you just do this until you usually do 1 to 1.5 volumes with it. But these are these dextran coated beads, and they bind your positively charged LDLs. So how does this work? We have a lot of theories on why it works. Some of the things we've already talked about. So cyclosporin, for example, doesn't bind well when you have high levels of cholesterol, right, or LDL. So if you can reduce the LDL, the initial thought process was, if we can get the lipids down, then maybe they'll respond to immunosuppression better. And that was the original thought process behind this. But we do know it decreases the macrophage stimulation caused by the oxidative LDL. And it really ameliorates a lot of that dysfunction in the macrophages. And then, but once you get reduction of macrophage dysfunction, you have a reduction of those inflammatory cytokines that we saw earlier. It does have a vasodilatory and anticoagulant effect by absorption of various pathogenic factors by the dextran sulfate. So it will reduce fibrinogen and coagulatory factors, but not like plasmapheresis. You don't have to worry about them bleeding and checking fibrinogen levels and all that pre and post. There is a reduction, but not to a bleeding risk like you see with plasmapheresis. It increases VEGF nitric oxide bradykinin production, and decreases thromboxane A2. And you really have to make sure they are not on an ACE or an ARB for at least, I like to take them off for a week. But they say, I think 48 hours. Y'all can correct me if that's wrong, because they do have that bradykinin production. Absorption of vascular permeability factor, and then enhancement of immunosuppressant response by improved intracellular drug transport. So improved corticosteroid response, enhancement of transmembrane cyclosporin A, like we talked about, and inhibitory effects on the MDR1 gene expression. So, and what's interesting is you actually get an increase in your IL-10, which is an anti-inflammatory cytokine. And so this is one of the few treatments that actually increases anti-inflammatory, which if IL-10 is high, you have less TGF beta. So this is a very, very good. So post FDA approval, the original study was less than 21 years of age, and this is when it first came out. They had to have a GFR of more than 60. They changed it to 18 kilos in 2016. The protocol was, and still is, you do twice a week sessions for 3 weeks, and then you do once a week session for 6 weeks. Hattori's group in Japan originally put patients on 1 per kilo per day of prednisone, and then tapered that off afterwards. Many people have changed this to various immunosuppression regimens to be able to do steroid avoidance now. So I want to go through some cases I've had and show you what I've learned about LDL apheresis since we've been doing it. This was the very first child I did, the youngest child. This was a 4-year-old patient who came to me from an outside center. She was diagnosed in December of 2012 with steroid-dependent nephrotic syndrome. They put her on tacrolimus in March. She didn't respond. They changed her to cyclosporin in August. She didn't respond. They gave her a course of piocytoxin. They biopsied her around this time, and she had minimal change with 5% global sclerosis, but no IFTA. They decided after the piocytoxin to put her back on Prograf. They got her in a partial remission at this point, but then by April, she was not responding to anything. Her GFR was still normal at this point. So in January of 2015, the family drove 4 hours to MUSC to see us. I ended up admitting her because she just was so edematous. Mom and Dad were saying she was maybe urinating once a day. I could put my finger a whole inch into her shins because she was so edematous. She weighed 20.4 kilos. Her GFR was 17 at the time. So for multiple reasons, she wasn't a candidate for the study. But I decided to do it anyway. So we gave her a dose of rituximab. I didn't go straight to LDL apheresis yet because I was still learning about LDL apheresis at the time. And I was a little, hadn't used it. And, so I said, well, let's try rituximab. And then she completely shut down, ended up going on CRRT. And this is her serum creatinine. So when she went on CRRT, I said, you know what? I don't know that I'm going to get her to respond. I'm either going to have to try this new therapy, LDL apheresis, or I'm going to have to take her kidneys out and get her transplanted. So I said, well, let's try LDL apheresis. This child had really, really, really bad response to steroids to the point where behavior problems. I mean, she was only maybe 6 or 7 at this time, but just a very, very, very bad response. Like the parents were like, please, whatever you do, please don't put her back on steroid. So we put her on LDL apheresis, and we were able to get her in remission. And she went in, you can see her LDLs pre, and then you can see her, or the blue And then the purple are your cholesterol pre, and then the triglycerides pre. They were just, you know, her triglycerides were getting higher and higher. Her urine protein creatinine around 2016. So after here, you could see her urine protein creatinine ratio was up into the 50s. So, I mean, just insane levels of high protein. And we actually got her into complete remission. This was her on her last treatment. And this was my very first patient that I did. I still see her. She went into remission in January 2016. She's had one relapse when we tried to take her off the MMF, and she actually developed a pulmonary embolus from her nephrotic syndrome because she decided to get a DVT and threw a PE, and she's back on MMF and in remission. And I don't know that I will take her off CellCept until she is done with her teen years. For the non-pediatricians in the group, children usually declare themselves around puberty. So for my girls, once they've hit puberty and started their menstrual cycle, I usually give them 6 months to a year, and then I'll start weaning immunosuppression, which is what I did with her, but she relapsed. So, but she's had one relapse since January of 2016 and has not had to have any further treatment except the MMF. And she's on half-dose MMF and stayed in remission. This was her when she presented. So you can see how little she was. So she was too young, too small for the study. Her GFR, she had AKI, but she actually responded even with the AKI. So one thing I've learned is if they have chronic, you know, CKD, you know, that's, you should not do this, but AKI, you do have a chance. This is actually a paper that came out last year talking about the treatment efficacy of LDL apheresis with patients with impaired renal function. And they looked at those with, I think the M was moderate, S was severe, and this was like mild function. But the N group, they're all of the urine proteins responded, got better. The moderate got better. The severe trended for better, but it was interesting that now people are starting to show that the GFRs actually are responding some when you are able to get the lipids out. And like we talked about before, when you look at the mechanism of the high lipids and the kidney damage, it makes sense that if you can get the lipids down, you might be able to recover some kidney function. But I think it depends on how far you've gone at that point. So lessons I learned from this case was that there is utility to using this treatment in children with AKI. We can now use it as safely as 18 kilos by the FDA. And like I said, our patient went from pretty much late 2015 to 2022 relapse free. And once we got her into relapse again, she's been in remission ever since. All right, our next patient, this was a 9-year-old African-American female who presented in May of 2017 with new onset nephrotic syndrome. Her mom had FSGS also. She's a single mom with 8 kids. She was started on steroids. About a year later, she was admitted with abdominal wall cellulitis. You can see right here. She also had spontaneous bacterial peritonitis and steroid-induced diabetes. She had AKI. Her creatinine was 1.3, fluid resistant. You could give her albumin and she'd put it right in her lungs and not pee it out. I mean, when we say fluid resistant, she laughed at albumin and Lasix. We ended up having to place a tunneled IJ for chronic albumin and Lasix, but really getting her ready for dialysis because we knew kind of that's where it was going. The family was really hesitant to do dialysis because mom was a single mom with 8 kids. So we really tried to maintain her with 3 times a week albumin and Lasix infusions in the outpatient unit. We might have gotten 500 mLs off with each infusion, but that was really kind of it. So this is a timeline of her. So we started prednisone at diagnosis. She got biopsied, had minimal change. We gave her rituximab twice in MMF. She did not respond. She had 11 admissions in 8 months. She spent 105 days in the hospital. All of these stars are her admissions. We started LDL apheresis here. This child, this is the only child in my entire career that I actually had to get permission to turn the water off in her room. She would drink so much that we had her on a fluid restriction. When everybody would go to sleep at night, she would drink from the sink. So we ended up having to turn the water off in her room. So she was getting admitted most of these times with just massive fluid overload. But admission after admission after admission. LDL finished here. And look how infrequent her admissions became. She ended up getting an E. coli line infection around this time. We pulled her line, and then she had no other admissions. So my point to that is, from here, she was not in complete remission. You can see her albumin level here is still less than 2. We didn't get her albumin up, for 2 more years above 3, but we were able to decrease her hospital utilization at that point. So we were able to get her into a partial remission here, which for a kid that was spent 105 days in the hospital over 11 months is significant. You can see the blue is pre, the orange is post. So her pre-triglycerides to post were significant. She had LDL cholesterols in the, close to 600 pre. She had triglycerides in the thousands. Her LDL was close to 400. Her total was close to 600. She just had crazy high levels that we were able to get close to normal with LDL treatment. So this child, you do have to watch your immunosuppression while you're giving them a central line. She did get a central line infection, but it did lead to decreased healthcare utilization overall with that partial remission. Now, we did end up taking her kidneys out, but LDL bought her about 5 years of partial remission. We actually transplanted her last week. She has recurrent FSGS, and we have started her back on LDL apheresis. So to be more to come on how she's going to do. Patient 3 is a 3-year-old male with nephrotic syndrome diagnosed in 2011, resistant to steroids. His biopsy showed minimal change disease, so they added MMF. There was no response. They weaned the steroids and started cyclosporin. If there's any trainees on this call, you go, well, why are some people using cyclosporin, some people using Tacro? Well, the old school thought was that cyclosporin would have a better response with some of the nephrotic syndromes, and so people would switch from one calcineurin to another. I've never really seen that to be true, but it has been reported. He self-weaned himself off of cyclosporin in 2014, or the family did. So, and he made it for about a year, and then he relapsed. We started steroids. He didn't respond to steroids. We restarted cyclosporin, and he was in remission for about 3 months. I'm not sure about his compliance at that point. 2016, he had a partial response to steroids. In 2017, he did have CKD. We increased the dose of cyclosporin to try to target a higher level. He went into a partial remission. We gave him rituximab, didn't really respond. We started lipopheresis. He didn't respond. We rebiopsied him, and at this point, he had 37.5% glomerular lesions, no tubular interstitial inflammation, but he did have interstitial fibrosis and tubular atrophy. So in 2018, he had both of his kidneys taken out. What I used for the first time in a child, now he's a big kid at this point, he's 16, 17 years old, is the double lumen ports, which I was not familiar with. This is a huge device, so I can't use this in my little kids, but they can actually do pheresis through these. These are like double lumen power ports. And this is his actual x-ray, and you can see it sits under the skin, and they can do 2 needles for pheresis and run through here, but it is a massive sized port. It's not small. But it was under the skin because we were a little squeamish after our last kid got the central line infection. So this was a great thing that we were able to use with him. And then in 2018, I got one of the scariest calls of my life. He got an accidental ABO incompatible transplant from a deceased donor. I got the call about 4 in the morning from my surgeon who said, we just found out this is an ABO incompatible. We've already anastomosed it in. He's making urine. What do you want us to do? I said, well, you've already put it in now. Just leave it and we'll see what we can do. So he was type O. He got an A kidney, not an A2 kidney. He got an A1 kidney. But fortunately, because he had gotten 2 doses of rituximab, his A titers were pretty low at 1 to 32. And I know you go, wow, that's not low. In Japan, they'll do ABO incompatible sometimes with titers up to 1 to 64. So in the grand scheme of things, it's not terrible. I did give him thymo. I started plasmapheresis because of the ABO incompatible transplant. I had a crash course in ABO incompatible transplant by talking to adult colleagues all over the country, getting everybody's protocols, trying to figure out how to managing this. 12 hours after transplant, he had a urine protein creatinine of 18.4. So it wasn't enough that he had an ABO incompatible. Of course, he had to reoccur with his FSGS. The orange line is his albumin. The blue line is his creatinine. And we started plasmapheresis, and I gave him 4 doses of rituximab, mostly because of the ABO incompatible. I usually only give 2 for recurrence. And you can see his creatinine, initially dropped. Went up, and then we were able to get it back down. His albumin kind of hung in this, 2.5 to 3 range or 3.5 range, but we were able to get that up. He did not go into remission with plasmapheresis, and we did plasmapheresis for about 3 months on him. He was in a partial remission, but he wasn't in a complete remission. And so we started LDL apheresis here, and we were able to get him in a complete remission with LDL apheresis at that point. His urine protein creatinine ratio, he still had a protein creatinine ratio of about 5 here, which was significantly less than where he started at 40. So he did have a partial remission, but we were able to get it to 0 after we started LDL apheresis. So this is actually a study that's really new that just came out this year, but they used applied computational phenotypes to a multi-center aggregation of electronic health records from 7 large pediatric data systems in the US to identify reoccurrence rates, risk factors, and treatment outcomes, and then refine the data by chart collection. And they compared children with primary FSGS, steroid-resistant nephrotic syndrome, who had a transplant between 2009 and 2020, who either had reoccurrence, so they had 67 with and 97 without. So they had a 40% reoccurrence rate in this population. And complete or partial remission chance was significantly higher with greater plasmapheresis sessions, CTLA-4 IgG doses, or LDL apheresis sessions. So this was very good data, and I was really happy to see that. And they said only treatment with anti-CD20 medications, CTLA4 Ig agents, or LDL apheresis sessions were associated with complete remission. And that's kind of what my last patient showed, right? We were able to get that child into a partial remission with plasmapheresis for 3 months, and we were doing 3 times a week sessions. But we couldn't get him into complete remission until we did LDL apheresis. So there is some brand new data coming out that really is starting to show that. And I think some of the reasons is because we're having this effect on lowering the lipids and allowing our medications to work. So lessons I learned from this case is that LDL-A can work when plasmapheresis does not. This double lumen power port was a game changer for us. And then you ask, so not everybody responds, right? And why do some kids respond and some don't? Well, this is a paper that looked at histological data for patients treated with LDL apheresis and prednisone therapy. And when you look at this, these patients, I kind of tried to copy and paste 2 charts together. Complete remission patients had no glomerular sclerosis, right? Or very minimal glomerular sclerosis and tubular atrophy scores compared to those who didn't. Okay, so I think once you get to a certain point of fibrosis in the kidney, it doesn't matter what they're going to give them, right? I don't think we know what that level is, but if you wait till, if you give years and years and years of treatments and they don't respond, adding on LDL apheresis is not going to reverse the fibrosis that's already there. If you want any kind of chance at trying to see if a treatment works, you need to give it earlier in the course before the fibrosis is actually taken effect. And they went on, they showed the age of onset. These are all pediatric patients of when they started the treatment, their prior treatments, whether they were on lipid-lowering drugs, their proteinuria, their albumin. But the patients that, definitely a lower GFR, you have a likelihood of going into end-stage renal failure if it's chronic, right? If it's not chronic, I've showed you there is a chance for that, but you can see all of the patients that had GFRs less than 66 pretty much went into end stage, and some of these other ones didn't. But this patient here with 3 years between diagnosis and onset of LDL, right? The other patients, 2.9 years, so 3 years between diagnosis and LDL. So I think this just also shows the longer you wait, the harder it's going to be to get these patients into remission. And then the Japanese group, once again, Hattori et al., they looked, and one of the things the two groups of patients who responded and didn't, what they really showed is that the patients with the reduced renal function were the ones that didn't respond. The higher glomerular lesions and the higher tubulointerstitial lesions are the ones that don't respond. So when you look at my patients, and we're almost done, patient 1 went into complete remission, patient 2 partial, patient 3 did not respond in the native, but did respond in the transplanted kidney. Our glomerular sclerosis in our native patient who did not respond was pretty high. None of our patients had tubular inflammation. Patient 3 did have IFTA, which is probably another reason why they didn't respond. And her GFR was lower, or his GFR was lower here. Patient 1 went into complete remission, but that was AKI. This was more of CKD, AKI on top of CKD. So I think it just kind of depends. But that patient did respond post. The biopsy, the first two had minimal change, but I put that in here because, did they have minimal change? They went into, or did they have FSGS that we just didn't catch on the biopsy? And so the final lesson learned here is all children are different. And so you have to treat them differently. And that is where we end up. There is CME and MOC credits available online. And this is how you claim your credits. And so we are now open to take questions.
Thank you, Dr. Twombley, for this elegant presentation. I loved it, and it actually matches my clinical experience as well in terms of the kidney function and the response rate. So I had 3 patients on LDL apheresis, 1 complete response, 1 partial response. His creatinine was like 2. The complete response creatinine was 0.8. Partial response creatinine was 1.5 to 2, was able to stabilize, were able to achieve partial remission. Proteinuria went down from 7 grams to around only 2 grams, but kidney function stable. Recently, in the setting of a viral infection, he seemed to have relapsed again. And these are all post-transplant patients, so we resumed the LDL apheresis. He just completed his 12 sessions, and like his proteinuria came down to 3 grams. His kidney function, which creatinine went up to 3.8, now it's 2.5 again. So I think we were able to achieve the second partial remission on him, and that will be the only thing we're gonna get. The third one, no. LDL apheresis maintained him, kept him out of trouble, but did not cure him, till the patient himself said, I cannot do this anymore. Then he went in hiding for 6 weeks without apheresis or LDL apheresis, and he came back with renal failure, massive proteinuria, nothing we could do to prevent the inevitable, and he just started dialysis 3 weeks ago. Again, his baseline kidney function was terrible, and he did not really respond to well. He was maintained, but did not respond. So I have no questions. I mean, I will encourage the participant to put the questions in the Q&A session or in the chat session. Okay, but I have a question which bothers me a little bit, and I think nobody on earth will answer this question better than you. And is how 6 or like 9 weeks or 12 sessions achieve a sustained response. I understand we are doing something during this apheresis sessions. We're removing the positively charged LDL, positively charged apolipoproteins, but how after we stop, continuation of therapy or continuation of response continues to happen?
So I think there's 2 reasons for it. Number one, I don't do LDL apheresis in silo. I always do it I typically use MMF. So I'll start the LDL apheresis and start them on MMF. And then I think the LDL apheresis allows the medications to work. So once you get them into the low lipid levels and give the medications a chance to actually work, they can stay in remission. Now, if they come off the meds and they get the high lipids again, you're going to be back in the same place. Now, there are some patients, and this is not FDA recommendation or approved, but there are some centers that have anecdotally reported patients who have relapsed a year and a half down the road, and they've done another round of LDL apheresis, and have been able to get their patients back into remission. I have not done that.
Like the patient I just described.
Yeah. Yep. And so I have not done that. If I keep them on some kind of low-level immunosuppression, if they go into remission, they usually stay in remission. But if you wean, like the one child that I did wean off, she got nephrotic, but we were able to get her back into remission because she hadn't been in it for months and months and months. Time she got swollen, her mom called us and we were able to get her in remission. So her lipids hadn't had time to get crazy high. But I think the big reason is you're giving the medication time to work. I'm not sure if you did LDL apheresis without any other medication, if you would get the sustained response.
These are all transplant patients, so they're typically on prednisone,
right,
Progress, and Cellcept, in addition to the LDL apheresis. I would say that with this hefty immunosuppression, sometimes we've seen BK and other viral reactivations, so we've been weaning off the Cellcept, but the person who fully responded is now off the Cellcept, and he continues to be off the Cellcept, and the patient who partially responded is also off the Cellcept, but on prednisone and Progress.
Yep.
So they're
but I think even pre-transplant, if you don't put them on something, the LDL apheresis itself might get them into remission temporarily, but if they're not in complete remission, they're just going to go right back. So I do think it has to be used in combination with something else.
Well, thank you for answering this question. I hope that one of the participants will share with us his or her question, but I still have more questions for you. What do you think about XR? I personally have no experience with it, okay? But in a recent ATC meeting, there was a talk about recurrent FSGS, and the speaker mentioned XR as a rescue treatment, or kind of had experience with it and felt it's a good option. I will ask you too about DARA, Mutunab, if you had any experience with it as well.
So Athgar, fun fact about Athgar, it is actually the only steroid that is actually FDA approved for nephrotic syndrome. I mean, if you go that far back. But Athgar, I've used it a few times pre-transplant, and I have never had anybody respond. Okay. I've used it maybe 4 or 5 times and didn't have anybody. I do think there's something about epigenetics of nephrotic syndrome. When you look at like throughout the country, in the South, and in South Carolina specifically, we have a lot of steroid-resistant, multi-drug resistant nephrotic syndrome. When you go up north in places like Michigan, and they have a lot of steroid-dependent nephrotic syndrome, right? And then when you go out west, they don't have as much nephrotic syndrome. But I think there's something environmental or epigenetic where different populations of patients are going to respond to different immunosuppression. And I think my population, Athgar, just does not do much. The second in my population. Now, you said ofatumumab was your I haven't used it. I have not used that, so I don't have.
That's probably more for an adult population. Okay, good. Thank you, Dr. Twombley, for answering my questions.
Of course.
I see one question from the participants, and it's an anonymous attendee. It says, if I use lipoprotein apheresis with a patient and she didn't achieve complete remission, but she improved, can we use it for another course or not?
You can. So LDL apheresis is FDA approved. You know, there's several indications for it. You can't do it on the post FDA approval study, but yes, you can absolutely. You have to go through the insurance process, and if the insurance covers it, then yes, you can absolutely do it. If you do it and get really good response of the lipids, I don't know the utility of doing another round that soon. It's just, you have to weigh the risk and benefits of leaving the access and doing more treatments, you know, the inconvenience of having to come back to the center. But if you have a reason where you think they're going to respond, there are people that have done that, done another course, and there have been some anecdotal cases of patients responding from that. But you know, one thing about LDL apheresis that I need to mention is LDL apheresis is not something where you do it and after 2 or 3 weeks you're going to be in complete remission. I've had patients that have not responded until the last treatment, or even a couple of weeks after the last treatment. It takes a while to get those lipids down and really see the effects of what that treatment is doing. You know, when they first started the post-approval study, some people were doing, you know, 2 weeks of treatment going, we're not seeing any response, we're switching to plasmapheresis. And we're like, no, you can't do that because you're not going to see a response that quick. So I think you have to give LDL apheresis time to work. You can't get anxious, especially with post-transplant reoccurrence, because, you know, you can do daily apheresis and have some kind of response, but if they don't bleed and get infected, you'll be, you know, lucky. And then you're going to be condemned to months and months and months of plasmapheresis. If you can be patient and let the LDL apheresis work and finish, most of the time you will not need to do another session. And and really look at your GFR. If your GFR is low, or if there's a lot of fibrosis on there, it's not going to benefit you no matter how many sessions you do.
Thank you, Dr. Twombley. I see no more questions. Time is now 8:02 Eastern time, so we're like right 2 minutes above the allocated time for us. With that, I would like to thank Opus Medicus for sponsoring this activity. And again, please go get your MOC credits. It's hard to get, and get the AMA credits as well. I would, on behalf of all the participants who stayed with us a whole hour, we have more than 20 participants here. And on behalf of myself, I would like to thank Dr. Twombley for not only her elegant presentation, but also for all her contribution to the pediatric and the pediatric transplant field. And I would really congratulate her on all her activities, and wonder how much she can find all this time to do all this. So with that, we'll bring this activity to an end, and thank you all, and see you next time in future presentation about LDL apheresis in pediatric and adult populations. Enjoy your day. Thank you.